Hi, I'm Dr. Eric Brader, and I'm here to talk about point-of-care ultrasound and specifically lower extremity DVT. We'll be going over two different types of studies, one for beginners, which is fairly effective, and then more advanced studies. Even if you never learn how to do the advanced study, it's good for you to learn about it so you can recognize when a good study has been done. So whenever you're doing an ultrasound study, you always want to use good technique. You want to have the machine in a place where you can view the screen as well as the patient. You don't want to be turning back and forth to manipulate your knobology. And ultrasound gel is very cheap. It helps with making better pictures. So liberal use of gel, a transmission gel, is key to getting good pictures and good studies. You need to know your limitations when you're starting out. If you're not sure, don't guess. And with regard to lower extremity DVT, one of the most important things I find if you're in a facility where you don't have immediately available ultrasonography, particularly overnight, and you anticoagulate enough people empirically waiting for a study, you're going to get bleeding complications. So I think it's a great study to learn how to do with regard to patient safety. So let's go over what ultrasound DVT clots look like. First of all, you want to locate the vessels and have some idea of the anatomy. There's lots of variation in anatomy, and the studies that I'm going to show you, the so-called normals of myself, I have some variations. So be ready for these. In general, arteries have thicker walls than the veins. The veins are much more collapsible. And what I tell people, the most important part with regard to doing a good study is the compression phase. And that's how you most often identify DVTs. And happy veins wink at you. So when you put pressure on them, they're going to close. And when you take the pressure off, it opens up. So when they wink at you, they're happy and there's no clot there. Clot is non-compressible. And when you do a good study, you always want to make sure the back and front wall touch to make sure there's no anechoic clot there that is deceiving you. If you try and compress hard enough, and oftentimes this occurs if you have an isoechoic clot, you can make the clot disappear, which means you now have a pulmonary embolism, which is obviously diagnostic, so you don't want to do that. So you don't want to press real hard when doing these studies. In looking at clot, when you recognize that you have a non-compressible vein, you want to also try and determine whether it's old or new clot. And this can be somewhat difficult and problematic. It's also helpful if you have old studies that you compare to your study, via a PAC system. In general, old clot is more echogenic. Acute clot is less echogenic. And if you look at the morphology, if you look at the clot and long axis, kind of ironically, if you will, the leading edge of the clot is often bullet-shaped, and bullets are dangerous, and so are large DVTs. Old clot oftentimes is more donut shape on short axis with when it recanalizes, often recanalizes centrally, so it kind of looks like a donut. It can also recanalize eccentrically, but usually the clot is eccentric and around the perimeter of the vein on short axis. So in order to get a good study, I advise not laying the patient completely flat. If you put the head of the bed up, you'll get more venous stasis in the lower extremities. You'll distend the veins, and it'll make your study easier to obtain. Particularly if you're having trouble visualizing the popliteal vein, you can hang their leg over the edge of the bed and do your study there, and that will provide additional distension to help you in determining where the popliteal vein is. You also want to externally rotate the leg to open up the medial portion, which is the place where you're going to be viewing the veins from, and maintain your patient privacy, obviously. They're not going to have their pants on. You're going to be pushing their legs apart, so have a towel or a gown or something to maintain their privacy. And when you're doing your study, use a linear probe. You want the index always painted towards patient right with regard to any short axis or transverse view of any sort of vein. That will always keep the orientation right and make sure when someone's reading it that they'll be able to determine, if you forget to label, whether you're working on the right or left leg. You should always, of course, label which side you're working on. Okay, so where I start out, there's the basic 2-point exam. We'll start with that. We'll go over that. We'll go over the more advanced exam, And then we'll go through a complete exam and work the 2-point in with a more advanced exam. So you put your probe in the groin crease and you look for the femoral artery and vein. It's best to get the junction of the greater saphenous with the femoral vein, and this is because oftentimes clots originate in the greater saphenous, and we'll circle back to this. And once you locate them, you want to do compression to the point where you make the anterior and posterior walls meet. Certainly you don't want to be pushing hard enough where you're seeing arterial compression. The point with regard to making sure you have the greater saphenous, and if you have clot that propagates up to the femoral vein, and technically you don't have to anticoagulate superficial veins, only the deep ones, but if it propagates to the junction of the greater saphenous and the femoral vein, there's a 10 to 20% risk that will propagate and create a deep vein thrombosis. So it's very important to be able to see this, and some folks will anticoagulate at this point. The second part of the 2-point exam is just going down to the popliteal fossa and swinging your probe around from the medial aspect posteriorly and find and compressing the popliteal vein. Popliteal vein, just like any other vein, thin wall. Oftentimes it's more superficial than the artery, but not necessarily, because there's individual variation. It's always good to look at the vein and the artery. You can put color on and see the arterial pulsation to help confirm what you have. And of course, the vein will much more easily compress than the artery if there's no clot there. So if you just do the proximal and distal technique and confirm there's compression, 98% of DVTs are detectable using this technique. So this is very helpful if you're trying to make up your mind whether to empirically anticoagulate someone, knowing that there are risks with anticoagulation. If you can identify a clot this way with 98% certainty, you're certainly, I think, doing your patient a benefit. Okay, so if you're going to do a more advanced technique and do a complete study, you're going to work your way down the medial aspect of the leg and compress the femoral vein every 2 centimeters all the way down to the popliteal fossa. You're going to do something called checking for phasic flow using the pulse wave Doppler. I tend to do this proximally, and you're going to look for what's called augmentation response, and we'll demonstrate what you do with that. You also want to identify a vein called the profundifemoral vein. This is a little distal from the junction of the greater saphenous. And it's a small, but it is considered a deep vein. It doesn't have as much clot load as the femoral vein, but if you get clot in here, there's a 10 to 20% chance of propagation. Most people consider this to be a deep vein and will anticoagulate if they see clot in the profundifemoral vein. When you get down further in the leg and you're working the femoral vein all the way down to the popliteal vein, when you get down to the distal third, your femoral vein will enter the adductor compartment. And this area is much more difficult to see the internal portion of the femoral vein, and we'll show you the tricks to maneuvers with regard to being able to see the appropriate compressibility in this part of the femoral vein. Okay, so this is a picture of a normal groin. Okay, so this is the left side. Your femoral artery is here. And it's riding over a little medially instead of top. Femoral vein here, and here's your greater saphenous coming out. It often looks just like bunny ears. And happy veins wink at you. So we compress, and we see how complete the compression is of the femoral vein as well as the greater saphenous. So I'm going to back up, and we'll make him wink at you. Okay. So now we're going to go down a little farther to the junction of the profundifemoral vein. And here's femoral vein. Here's femoral artery. And we've lost the greater saphenous. It's out of the picture now. And this is my profundifemoral vein. And usually they come out more inferiorly. Mine kind of came out a little sideways. And right before the profundifemoral vein comes off, you'll see the profundifemoral arteries come off, of which I have 2 instead of 1. So once again, you're going to look and identify the arteries in the vein. You see here's an artery, thicker wall, thinner wall right above with the femoral vein and profundifemoral vein. And we're going to compress again. And you always want to document compressed and non-compressed, because if you're compressed and have a picture of wide open veins, you probably have anechoic clot. And you don't want to leave the person who's looking at your study thinking, well, is this non-compressed and normal, or is this compressed with anechoic clot? So always document whether it's compressed or non-compressed. And so there we go. So we compressed, and we can see my profundifemoral vein, my femoral vein are all compressed, and my 3 femoral artery branches are non-compressed. So you slide every 2 centimeters going down the leg. We're at the mid portion of the femoral of the thigh right now. We have femoral artery, femoral vein down here. And if you're sneaking a little peek over here, I have a little accessory vein sitting right here. Everybody's different. For some reason, I have a lot of variance, but that's good for training purposes. So femoral artery, femoral vein, compression. See, the femoral artery is not compressed, so I'm not pushing too hard. And once again, we'll make them wink at you. Okay. So now we're down in the adductor canal, and this is the most common place to miss clots, or one of the most common places to miss clots. You can see how bright this tissue is around here, and it bleeds over into your artery and your vein. In addition, these are right down near your femur. So, and they're in a position where it can be hard to compress the femoral vein. So there's a couple tricks to being able to do this. You can take your probe and you toe in the lower aspect like this and compress with just the corner of the probe, trying to get around the femoral artery and compress. Or you grab the hamstring with one hand, hold your probe, and push your hamstring up towards the probe and compress the patient's femoral vein using their hamstring rather than trying to mash down with the probe. Oftentimes, if you mash and mash with the probe in kind of a standard position, you won't get any compression. So with this one, I use the toe-in technique, and we have good compression there. I left a tiny little bit of a gap there, but it did compress completely. Just go back and forth. Okay, so now we're down in the popliteal fossa. Usually the popliteal vein is more superficial, but not always. And we can see here popliteal vein. We're already getting down to trifurcation right here of different branches coming off. Femoral artery here. Down here is your popliteal fossa. Not sure whether that's going to be tibia or femur there. But anyhow, nice and anechoic. And we're going to do compression again. And the popliteal fossa is uncompressed, and the veins all disappear. Back, forth, back, forth. So now you're confident that if this was just if this is your second view in the 2 view, and you've had compression proximally and distally, 98% chance you don't have a DVT. So this would conclude your study with regard to determining that this patient does not have any DVTs, at least in the upper thigh. This does not go down in the calf, obviously, and you can still have calf clot. Calf clot can often be watched and with serial ultrasound, although some folks will put the patient on a NOAC at this point just to avoid any concerns with propagation. Okay, so some other advanced techniques that are good to know, but at least to be able to read and understand when you're looking at a Doppler study is something called normal respiratory phasic flow. You go to pulse wave, you press the pulse wave button, maneuver your sample gate down to the femoral vein, this proximal femoral vein, and your sample gate usually has a default of opening up about 2 millimeters. There's a control that you can open it up wider, so you get a better selection with regard to the flow that you have, and it becomes more sensitive that way. And then you hit the pulse wave button again, and you watch this spectral Doppler pattern of flow in the vessel. When you inspire, if your iliac is open, if your IVC is open to your thoracic cavity, the negative inspiratory force in your chest will force blood to return more quickly, and you'll see more venous hum. When you exhale, you retard venous flow, and you'll see reduction in flow. So all that implies is you don't have iliac clot, you don't have IVC clot. So you always want to see good respiratory phasic flow because, particularly in cancer patients, they tend to get iliac vein DVTs due to their tumor burden, I think, in their abdomen. And they can have a leg that looks like a DVT, and you put the probe on and everything compresses and you're scratching your head. Well, this is the person to look for respiratory phasic flow, because if they clot in their iliac, their leg will swell up just like a, if you want to call it a generic DVT, but their phasic flow will not be normal. And we'll show examples of that. This is an augmentation response. This is, once again, you have your pulse wave position. I just keep it in the same place in the proximal femoral, and give their calf a squeeze. And this accelerates flow up the femoral vein system. And you see the big fancy swoosh right there, we'll call it, yeah, right there. And that's what happens when you squeeze. Now, if you don't get a good squeeze the first time and just keep squeezing, you'll deplete the lower leg of venous blood, and you won't see any response. So in between squeezes, you have to give it a little bit of break to let blood reaccumulate, or you can get a bad result. Okay, so this is a patient that actually does have DVT, and this is the junction of the femoral vein. Here's greater saph here. Here's the femoral vein here. And we're going to go to compress. And you can see that nothing happens. And so that's why it's important, because they kind of look the same. And it's important to document that this is compressed, and it really didn't go anywhere. So this is a patient with a DVT. So if you're doing point of care, you can just stop right now if all you want to do is diagnose whether they have a DVT or not, rather than working their way down and pushing and looking for the extent of your clot. You know you have proximal clot at this point, and you've made your diagnosis. On the same patient, this is pulse wave, and I leave my pulse wave in the same position to look for my respiratory phasic flow. And in this case, you have no venous hum right there. And here's an augmentation that I attempted to do, and you see how, if you want to call it lame, that spike in flow is. And that indicates to me that the whole system is likely virtually clot, because we're not pushing any blood up through the sample gate here. So this is a very positive study, a high clot load patient. When you do pulse wave, you always want to go over to the unaffected side just to compare. And here's good respiratory phasic flow once again. Here's expiration, here's inspiration with acceleration. So in the same patient, it lets you know, particularly this is important to people with IVC filters, because if, for instance, their filter's clogged or they have IVC clot, when you go over to the so-called unaffected side, you'll see that same poor respiratory phasic flow, and anatomically what that tells you is that you have IVC clot, or if you have an IVC umbrella catheter, that it is clotted. So it gives you an indirect means of determining what your clot load is upstream. Okay, and finally, here's a long axis clot. These are old slides that didn't reproduce very well. And here's this bullet-shaped contour that you see with the DVT and long axis. This is femoral vein once again. Up here's femoral artery. And you can see the bullet-type contour. And once you see some of these, they're really kind of frightening, because you see this little gap right here. Most DVTs aren't attached very well to the venous walls, and you just may see a thin strand that's holding the DVT in place. And right in this little gap we saw right here, you'll see flow. And the DVT isn't attached either rear wall or front wall. It's just hanging by a thread, literally. So I say this just as reinforcement. Don't mash on your DVT patients because these DVTs are highly tenuous in their attachment and it's easy to mobilize them. But this is representative of that bullet shape to the top of the DVT, and even though it looks a little bright, it was an acute DVT. One of the other things to look for when you're doing this study, oftentimes these patients are partially anticoagulated, they've had a prior DVT, they come in, their calf hurts and it's swollen, and they're concerned there's a DVT. Well, one of the things you can do and to determine what's going on, you go down through it and it's a negative DVT study and you're sitting there wondering, well, why is their calf swollen? Why does their calf hurt? Well, if they're partially anticoagulated, say they're on Coumadin, maybe their INR is 1.4, and okay, they're not fully anticoagulated, maybe they could have a DVT, but they're also more prone to bleeding. And this is a gastroc compartment here, and this is what a hematoma looks like. So you'll also see people come in with spontaneous hematomas, spontaneous bleeding in their gastroc, and this causes a painful swollen leg. And so you get the opposite type of complication, and this is a patient you may want to, depending on the extent of the bleeding and how swollen and how tender it is, whether you want to discontinue their anticoagulation temporarily while this is going on. But it's always nice to give your patient an answer, particularly if, for instance, in your vascular department, they don't look in the calf for soft tissue issues. This is one that's really easy to diagnose. Thank you.